Uh, Assalamualaikum warahmatullahi wabarakatuh. Can you all hear me?
Waalaikumsalam, Prof. We can hear you.
What? Just now I gave salam with my computer. Tak dengar
Tak dengar, Prof.
Tak dengar Let me present. Let me try whether, because I'm somewhere else. With the internet, which is the problem, because I'm using my handphone, is okay. You must grant permission in order to screen share. Is that why I can't screen share? That anybody else is sharing or? Hold on, Okay. Ain is Ain there?
Yes, Prof.
Yeah, to make it easy, maybe I will have to send my slides to you now, and then you can present. I'm having problem. I don't know why. It's probably due to the internet. No video, no pictures of me, and no live video, and no presentation. I'm sending this. Okay, I'm sending it to you. I got to go out for a while from the computer. Compose. Pause.
Not in presentation mode, but still we can see, Prof.
Sebab presentation mode. Why is this mirroring your presentation mode? Okay. Tak mau gerak pula. Oh my god, what happened to my computer? I really got to buy a new one. You inilah present lah. Okay. Boleh you ada komputer?
Ada, Prof. Sekejap, Prof.
You try, I mean, I think it will give more problem. Dia tak boleh nak klik. Tak boleh nak. I don't know why. I stop presenting first and then present again. Bolehkah nampak ni sekarang?
Nampak,
Hello?
Prof. Nampak, Prof.
Okay, sekarang saya change. Nampak tak? Saya tukar
tak
sekarang
nampak,
nampak?
Prof. Tak, still
nampak,
sama slide satu.
Sekarang? Tak nampak ke?
Still tak, Prof.
Oh my god.
Yang ni nampak, Prof.
Yang ni nampak ya. Yang ni selalu kalau selalunya kalau saya gerakkan yang ni selalu nampak. Yang ni nampak kan?
Prof, I think Ibrahim can present the screen, Prof.
Okay. Ibrahim wants to present the screen. Okay. Continue. Saya
you need to stop the presenting first. Just stop.
Okay, hold on. Stop presentation. Mana shop service? Okay. Sorry for that. Let's stop presentation. Okay. Okay, last time we did go through external ear external ear problems. We were talking about the common problems in the external ear. There were some things missing. For example, the trauma to the ear. So in the slides, added on that, and I didn't tell you about the examination of the ear. Are you okay, Ibrahim? Not yet, eh? Okay. How do we diagnose? First, we examine the ear, and then we palpate for tenderness. We'll ask the patient whether there's any tenderness or not. If they say yes, then how do you determine where the problem is? For example, in the auditory external, where the problem is, where is the pain? So usually we palpate at the tragus. If it's a tragus, usually the pain is at the external ear canal, anterior wall, and we can also pull the auricle. We can pull the helix, the auricle, the ear. If there's pain there, then there is tenderness of folliculitis or edema, swelling at the posterior canal wall. Okay. Brian, if you have got it, you tell me, because I'm on another page. But okay. Next, please. Okay, this is what I'm saying. The tragus in front, if you palpate, there's pain, there's anterior maybe infection or swelling, edema, folliculitis or franculosis. If you pull the helix, then there'll be pain posteriorly. So in that case, when there's pain, we don't try to examine with the headlight, not with the oriscope. So there'll be some tenderness if you put in the scope there. Next. Next, please. Next. Okay. Here, just to tell you that the EAC is lined by stratified squamous epithelium. Those who were in the clinic yesterday, we saw one girl who was very in pain, great pain, and she was also painful at night. And when she was chewing, opening the mouth, yeah, or touching the tragus, the ear, then there's a lot of pain. And well, when we try to meddle with the ear, try to do otoscopy or try to suck the ear, there was extreme pain, and she was in tears. So why is there pain? Because the EAC is lined by stratified squamous epithelium, like the normal skin. It's got a lot of sensory cells, hair cells, sensory nerves. The subcutaneous layer of the cartilaginous portion, the external 1/3 part of the canal, contains hair follicles, sebaceous glands and ceruminous glands. So this can be infected, the hair follicles, the sebaceous gland, and the skin thickness. At the cartilaginous part, it is 1 millimeter. 1 millimeter is very small, but it is, as compared to the osseous part or the bony part, it's only 0.2. It's very adherent. But luckily, at the osseous part, there's no no hair follicles to get infected. Yeah. So the epithelium, the EAC migrates, and also just to tell you that the epithelium, the EAC migrates laterally from the eardrum outside at about 0.07 millimeter per day. It's about, they take about 2 months or 3 months to if you put an ink at the eardrum, it will take about 2-3 months to come out. The ink will migrate out. Yeah? What I'm trying to tell you now is that the skin is adherent, very adherent to the cartilage or the bone. So any expansion between the skin and the perichondrium or skin and the periosteum, they will cause a lot of pain. Remember, if you have if you have an abscess in the buttocks, the pain is tolerable still, or ada jerawat batu pun, it can be big. But in the ear, very small, tiny inflammation. Folliculitis means the follicles, the hair follicles get infected, get red. You get swelling and edema there. Maybe it's just a small swelling, but the pain is terrible. Yeah. So when you become a doctor, when they say there's a lot of pain, you have to check outside. Check at that hairy part. Don't just put in your otoscope. Check outside first for any inflammation. It may be mild, but the effect is great. Okay. Next, Brian, please. Okay, here. Yeah, this is just to illustrate at the outer third of the one-third of the outer third of the ear canal, you have the hair follicles. Yeah, if you see when you put the otoscope in, while you put otoscope, you use a speculum because you want to avoid that hair so that you can see inside. So your hair is only outside, but that is a place where there's the wax, the cerumen is being produced, ceruminous glands, because there are ceruminous glands there. Yeah? Cerumen prevents the canal maceration, maknanya becomes sodden, it becomes excoriated, and it has antibacterial properties actually, and has a normally acidic pH. So all these are antibacterial, all of which contribute to an antibacterial effect of that cerumen. So if you keep on cleaning your ears with the for example, with the cotton bud, especially every day, you think that's very smart, that's very clean, because nama dia tahi telinga, so you clean it every day. Sebelum solat, contohnya. That's crazy, isn't it? Because that mild manipulation every day will cause excoriation. Once the skin, the squamous epithelium, is being breached, then you will have infection. Yeah? You put tahi lembu or tahi kucing, whatever, on the skin, it's no problem. But if there's a wound there, then that bacteria can go in, or that fungus can go in and get infected. Okay? So, never clean the ears. Neman, go ahead. Next. Never get the habit of cleaning the ears frequently. Or I would say, don't use a cotton bud frequently, because when you use a cotton bud, you push the earwax inside. It's supposed to be in the external third of the external third. When you push inside, it get impacted into the near the eardrum, and you get conductive deafness. Okay. So never use a cotton bud. You have the cotton bud at home, use it for your umbilicus or feet or anything else, for your makeup. Next. Right, next. Okay, human prevent water from and in canal causing maceration. So Pseudomonas aeruginosa, Staph aureus, all these, then the straps can only infect you if there is a breach in the skin. Next. Risk factor for otitis externa skin is if breach can cause infection. I told you just now. If you're swimming in a dirty environment, dirty water, high humidity. In Malaysia, they get commonly this otitis externa because it's very humid. Humid is good media for bacteria and also for fungus. And especially those who have got allergy, eczema, psoriasis, seborrheic dermatitis, so it's itchy. So they keep on trying to rub their ears, garu ataupun because it's so itchy. When you manipulate the ears, you'll get all those fine, very fine breach in the skin. You can clean your ears. I'm not saying that you cannot clean at all your ears. Yeah, you can clean whatever reach with the finger with short nails. You use a tissue and put it in your ears after you take your bath or your towel. So it only reach outside, and the direction should be out. You flick it out so that it falls down. Okay, next. So now we go into otitis externa. Next. Yeah. So in otitis externa, it can be localized, as I mentioned just now, folliculitis, localized at one follicle, or it can be generalized. Okay. And the main symptoms will be a lot of pain. There will be otorrhea, there will be ear discharge, but scanty, because in the external ear, there's no mucus. There will be pus, there will be serous, but no mucus, like macam hingus, like your running nose. That will be only available from your middle ear if there's a profession. But just the external ear infection will cause very thick discharge. Yeah, maybe yellowish, maybe whitish. It's like your skin when you scratch, then it become excoriated, and there will be exudates. The exudates yellow in color. So there may be fever, there may be pain, a lot of pain on moving the ear, and the canal may be edematous and obscured with debris, discharge, blood, or inflammation. And there may be lymph nodes surrounding that, may be inflamed because of the infection. Infection draining into the lymph nodes. This is just a view of a normal tympanic membrane. Tympanic membrane is part, the external part. Tympanic, there's 3 layers. Squamous epithelium layers is part of the external ear. Then you have the middle fibers. Then you have the inner mucosa. Next. When otitis externa, sometimes from that infection, it can get worse. From that small infection in diabetes in people with immune response, poor immune response, they'll get what we call malignant otitis externa, MEO or MOE, malignant otitis externa. It's not a malignancy, but it's very painful condition. It's an infection, usually from Pseudomonas. Next. Okay, this is an example of a furuncle or folliculitis at the hairy area. And the management usually is you can put topical antibiotic drops, neomycin, polymyxin, whatever, Taravit, ciprofloxacin or Taravit, or otic steroid drops like Posid H and analgesics. Next. You need a lot of analgesic because painful. But, okay. But actually the more effective, there are some other slides behind, the more effective treatment would be to put ribbon gauze, put in with ectomol glycerin wick. Ectomol glycerin, which is, ectomol is antiseptic, and it can astringent as well. It absorbs the edema. Is also anti-inflammatory. You place it there for 2-3 days. You ask the patient to come again. After 2 days, you take out the wick, and usually they will heal. Plus systemic antibiotics also. Okay, next, chronic otitis externa. If it's more than 4 weeks, then it's chronic otitis externa.
Assalamualaikum, Prof.
Then,
This
yes.
topic I did be present. We only present otitis media.
Okay, yeah. Ini habis dah. Okay, continue. Next. Kita laju sikit. These are example of otomycosis. Ini continue. Tunjuk otomycosis. Tadi I've added some slides actually. Tunjuk tadi the gambar of the otomycosis, Aspergillus nigrans and albicans. One more. Yeah. This is how you will look at it, the hyphae, and the spores. Okay, next. External, chronic otitis externa, all this esquamation, a lot of itchiness. Next. This is, that is the candid eardrops that we like to use. Okay, next. You can cover fungus. Sometimes we use powder, clotrimazole powder. Okay, this is a bit about meningitis. I think we have talked about it before. It's a stomatitis of base of skull. It's very, very painful. The patient will want to knock the head. In diabetics especially, and Pseudomonas is the main organism. Next. And we can do a technician scan, bone scan. You can see that that area is inflamed. Okay, next. And it can even cause facial nerve palsy, other cranial nerve palsy, and it can go to the other side of the ear. Okay, I mentioned that before, I think. Okay, next. Complication include sepsis, cranial nerve palsy, meningitis, and so on. Okay, we need long-term antibiotics, especially ciprofloxacin, sometimes 3 months, 6 months, or 1 year. IV, and then we change to oral. Next. Rarely we do surgery. So okay, other causes, cerumen, wax, which blocks the ear canal. You see in the clinic there are many cases with earwax, and we take a long time to clean it. We can either use water, irrigation, or we can use instrumentation, like a hook, or we call it Jobson horn, or we can use suction. Next. Okay, that's an example of the wax. It will cover. If it covers and it touches the The TM, there will be some pain, and also there will be some deafness. Kalau sikit tak apa, but wax, if it's up to the eardrum, it will cause some deafness, about sometimes even 20 decibels, 30 decibels. It can be even negative rhinitis, but usually it's still positive rhinitis. Okay, next. This is how you clean it. I mentioned this now. If there's a lot of impacted, very tight, very compact wax, then we give ear drops for a long time, 2 weeks, 3 weeks. Yeah, sodium bicarb, or there are some other cerumen, they call it cerumenex, or apa dia panggil, wax sol, the many brands. Yeah, but simple one, sodium bicarb, you buat cake, dia kembang and naik. Next. Then foreign body, I mentioned about batteries last time. Okay, next. And pirah ataupun kutu babi. And then, foreign body. Foreign body in the ear is not as bad as foreign body in the nose. The nose, because of the mucus, it reacts. Except for battery. Battery, it reacts in the ear as well. Next. And I think I mentioned about inorganic, organic foreign body kan. Kalau a big bean, then you try to irrigate water, it will swell up and difficult to remove it. Yeah. Okay, I think we have mentioned this. Next, foreign body. Kalau insect, we have to kill the insect first. For example, nyamuk, you put olive oil or cooking oil, it will die. Or lipas. Yeah. At home, you just use the oil. After that, the doctor will remove for you. Okay. But pirah ataupun kutu babi or ticks, ear ticks, they don't die with the oil and the usual thing. Alcohol pun dia jadi mabuk, dia jadi. Yeah. So it's quite difficult to kill them. Next. There's bullous meningitis. There is bullae at the eardrum due to viral infection, like the bullae that you see in HFMD, hand, HF, face, mouth disease. Yeah. Foot, sorry, F is foot. Next. It may extend to the canal as well. So, like this. This may look like a bullae if it's on the eardrum. If it's in the external ear canal, it looks like a kutu babi yang dah kenyang. Okay. A full blood sucking tick. Okay, next. Well, this is a differential diagnosis. Can be malignancy as well. Next. So sometimes we give antibiotics if just we suspect any bacterial infection. Otherwise, we give painkillers, analgesics. If the vesicle is too big, we can just rupture it. Next. Perforation can be for any cause, trauma, teacher slap you, yeah, infection, pressure build up, and so on. Yeah, next. Oh, so I missed some of the. It's missing. Trauma to the ear. Okay, I can just mention. Now it is tympanic membrane. This is middle ear dah. Okay. Trauma to the ear, you have some conditions where the boxes ear. Maknanya there will be perichondritis. The ear, the whole auricle gets swollen, get thickened, get swollen due to always trauma to the ear, or hematoma. Sometimes blood in the below the skin of the ear. So they get a hematoma. And then hematoma can get organized, become a fibrosis, and it will curl up, becomes what we call a cauliflower ear. A cauliflower ear. Yeah. Okay. Okay, and that, how do we treat that? During the acute stage, if there's blood in the auricle, in the below the skin, or below the pericordium, then we have to drain it either with using a needle, suck it with a syringe, or we do a IND, incision drainage. And the problem is how to keep it, what do you call, how to keep it closed. You know, once we drain it, if we have to compact it, we have to put pressure on it. Either put a pressure dressing, or some people put a button there, suture button. There's some other techniques. If you don't do that, it will reaccumulate again below the skin. Yeah. So, okay, that is the trauma, and then maybe sometimes laceration to the auricle. You need to suture it properly. Yeah. Okay, now the tympanic membrane, perforated TM. So as I mentioned, perforated TM, there are many causes to it. Besides inflammation, is trauma. Yeah. So it will cause sudden severe pain, hearing loss, then there will be ear discharge. And otoscopic exam reveals puncture in the tympanic membrane, perforation in the tympanic membrane. About otitis media, acute otitis media, at the end of the slides presentation, I have the detail. Yeah. So, okay, different diagnoses include acute and chronic otitis media. When there's perforated TM with discharge, the complication include secondary infection into inner ear. Next, okay, I'll just mention about the complication is not complete. Complication, imagine the ear. You imagine my ear here. If you can see me, it can go inside medial to the labyrinth. It can cause deafness. Can cause infection, bronchitis, or it can go up. It can go to the brain. It can cause extradural abscess. It can cause meningitis. It can cause subdural. It can cause brain abscess, either superiorly at the midbrain or posteriorly at the posterior cranial fossa. Or it can cause also other complication includes facial nerve palsy when it affects the facial nerve, which is in the middle ear and the mastoid. Yeah, the swelling and the edema can cause facial nerve to be compressed. Other complications include they can be an abscess. Yeah, the media can become mastoiditis and abscess. Yeah, the abscess can be behind the ear. It can be anterior to the ear. Can be even can go down from the tip. Mastoid tip can go down to the neck. Next, antibiotics to prevent infection. Yeah, the management, we give antibiotics to prevent infection or treat existing infection. Surgical repair later when it's dry for 6 months at least. Then we do a meningoplasty if that is necessary. Next, not in the very young children. Next, yeah. So this middle ear, it can be due acute otitis media can be viral respiratory infections, cause inflammation of the eustachian tube. Most of the problem is from the eustachian tube, which is in the nose. So in acute otitis media, we treat the nose a lot because in acute stage, before stage of perforation, if we give ear drops, it won't go into the middle ear. So we've got to give systemic antibiotics, nasal sprays, nasal drops, nasal decongestants. So when the eustachian tube is blocked, it will cause a cavity, a negative pressure in that cavity can cause fluid effusion from the capillaries. Yeah? And can cause, and then plus infection will cause discharge. Next, it causes inflammation. In the West, it's common in winter. In Malaysia, not so prominent. Then eustachian tube in children are shorter, so they can have more episodes of acute otitis media as compared to adults. And the bacteria, Streptococcus pneumoniae or Haemophilus influenza, example, and risk in that is in the acute stage. In the chronic stage, usually is Pseudomonas, Mozzarella catarrhalis. Then you have risk including upper respiratory tract infection. If there's a smoker at home, you've got allergy, you've got cleft palate because the suction tube is always patterned, so infection can go in. Adenoid hypertrophy is very common with otitis media, acute otitis media, so you have to treat that. If you have bottle feeding and in a child 1 year old or 6 months and they are lying flat, they should be raised a bit so that there's not much of regurg to the nasopharynx. Or breastfeeding, of course, is better, is best. Okay, barotrauma can also cause that. Next, please. So this is an example comparing a normal ear and inflamed ear, middle ear, yeah. Acute otitis media. You can see that it's inflamed, dull, loss of corneal light. You cannot even see where the handle of malleus sits. The normal one you can see, that's the normal in the left ear. The abnormal also in the left ear, if it's inflamed, it's bulging. Something you get in your OSCE for your exams, you get a picture like this and what is your possible diagnosis, what is the problem? Yeah. There can be conductive hearing loss, ear pain. Ear pain in children is usually at night. Why at night? You all know the answer, because at night you don't swallow much. Okay? You don't swallow because swallowing opens up the suction tube. So at night, especially children, they sleep. The swallowing reflex is not there, so the suction tube is always closed and the pressure builds. Okay? Sebab orang aliok basi keluar tak swallow. There'll be vomiting. In children, they may, with acute otitis media, they may have vomiting as well, diarrhea, and infection caused in children. They can have fever, the TM is bulging, red, and there's no right or poor or distorted light reflex. And if you introduce air with pneumatic otoscope or they do Valsalva, you cannot see the movement or decrease the movement of the eardrum. Next. So we do a tympanometry to see the pressure of the ear that doesn't move. It's a type B TIMS. Diffusion analysis includes acute otitis media may have a perforation. It's a tympanic membrane with a perforation, or tympanosclerosis. The eardrum is whitish, is pale, yeah, opaque, or recurrent otitis externa media when it occurs recurrently, or maybe mastoiditis. Mastoiditis, there will be pain, fever, and they will have tender. They will have tender at the mastoid. Mastoid is behind the ear, but the tenderness is either behind or at below here, mastoid tip, or at the Simba concha. Simba concha is inside here. When you press it, but the Simba concha lies above the antrum, mastoid antrum. So they may just have inflammation there. Next. They need analgesics, antipyretics. They need antibiotics, example, Augmentin. Decongestant the nose. We have to attack the nose. That's a decongestant. They have allergic rhinitis. We give even steroid nasal sprays. We give oxymetazoline nasal drops, which you can use only for 1 week. Otherwise, there will be a rebound phenomena. Oxymetazoline constrict the blood vessels and it causes vasoconstriction. It's a group of ephedrine, group of ephedrine drugs, and antihistamine if there's allergy. Next. If there's bulging, really bulging, pain, and impending rupture of the eardrum, then you do a laryngotomy so that the pus will come out. Bisul is like an abscess, you need to drain it. And the advantage of laryngotomy is that you will create a very nice incision and the pus will come out. But if you wait for the pus to burst, the perforation may be ragged, may be big, large, then there's a possibility of non-healing of the perforation. Okay? Next. So, the complications, there may be persistent perforation, or the perforation may heal, but there will be tympanosclerosis. You can see calcification of the eardrum. There may be, it can turn, acute otitis media can be recurrent, they turn into recurrent acute otitis media, or they can turn into chronic otitis media with perforation and discharge off and on. It can be acute or chronic as well. Yeah. Chronic can be with discharge or without discharge. Persistent middle ear effusion can persistent middle ear effusion can cause mastocytitis and bacteremia. Next. When you say about recurrent otitis media, when we have 4 episodes in a year, and sometimes we prevent that by antibiotic prophylaxis or pneumococcus vaccine, adenoid tubes. If they have got recurrent effusion infection, we can put a grommet tube so that any discharge can come out early. And we have to do adenoidectomy if there's adenoid enlarged. Next. Okay, otitis media with effusion. This is a separate entity. Otitis media with effusion, sometimes we call it OME, sometimes SOM, secretory otitis media. Yeah. It's when fluid accumulates behind the TM in the middle ear. Yeah. This is due to negative pressure and fluid in the suction tube. The suction tube is closed, so they'll create a negative pressure, so they'll cause fluid effusion to come out from the capillaries of the mucosa. So common in children because of sometimes children with cleft palate, about 90% of them will have effusion, or due to allergies, or due to barotrauma, go up the plane, down the plane. Yeah. Okay, next, please. There'll be hearing loss. Yeah. There'll be fullness, pressure, feeling of pressure in the ear. The eardrum can look dull, can look retracted, gray or pink. There'll be decrease in the TM mobility. Okay, and it's difficult to see the landmarks as well. You do a tympanometry, you'll see a type B tympanometry or type C if there's a suction tube dysfunction. Type B, when there's a lot of fluid. Yeah. Audiometry, you have hearing loss, airborne gap, conductive hearing loss. In addition, that this includes acute otitis media, malignant tumors to the nasal cavity, and cystic fibrosis. Yeah, this is very important. Sometimes you have OME, you have tinnitus, OME. You have to rule in Malaysia, among the Chinese, among the Malays, not the Indians. You have to rule out nasopharyngeal carcinoma, NPC. So it's a must that you scope, the ENT will scope the nose. Yeah, because in the early stage, nasopharyngeal carcinoma will only present with acute, with otitis media with effusion. You block the ears. You block the eustachian tube. Nasopharyngeal carcinoma is situated near the eustachian tube at the what they call the fossa of Rosenmuller, at the superior part of the eustachian tube. As such, there will be eustachian tube function, dysfunction. So you will get effusion in the middle ear. You get some tinnitus. Other symptoms of nasopharyngeal carcinoma is that they'll have a bit of blood-stained saliva or nasal discharge. They can also have lymph nodes that is very late, or nerve palsies. The 6 nerve palsy, 7 nerve palsy, that will be very, very late. That means it has gone to intracranial. Next. So how to treat middle ear effusion? Yeah, because the eardrum is intact in OME, it's useless to give So it's important to give decongestants. Yeah, we don't give eardrop, we give nasal decongestants, or we may give oral steroid. It is nasal steroids we may give. The steroid helps in the inflammation and decrease the congestion. We can give antibiotics. Antibiotic is not the main treatment for OME. OME is supposed to be, the fluid is supposed to be sterile. There's no infection. It can get complicated, but usually it is, yes, there's no infection. Meningotomy, when there's already chronic, more than 2 months, 3 months, more than 3 months, when there's no resolve, it's unresolved, then we do a meningotomy, we put a tube in, what we call a ventilation tube or grommet tube. Sometimes we do put in a T-tube. There are several types of tube, the long-term, mid-term, or short-term. The T-tubes, T-shape, it's long-term because the flanges are big. The other grommet, the flange is not so big, so they can be dispelled out. Next. There can be recurrent or persistent otitis media due to eustachian tube dysfunction. The risks are more in allergy, in multiple infection, ear trauma, swelling to adenoids. Okay, they may get infected. As I told you, OME, chronic otitis media is different. Chronic otitis media is okay, next. It can cause chronic otitis media, or sometimes we call it chronic suppurative otitis media, where there is pus in the middle ear. It causes long-term damage to middle ear due to the infection and inflammation, including again, there are 2 types of chronic otitis media. One is the chronic suppurative otitis media. One is just the chronic otitis media as a sequelae of secretory otitis media. In secretory otitis media, if it's chronic, then the discharge, the effusion turn to become glue, what we call glue. There'll be will be inflammatory cells there, and then there will be fibrin, which causes it to be very viscid, very thick discharge. It's like glue. And that can cause erosion of the bone. Why erosion? Because when there is glue and there's more negative pressure, the eardrum is being retracted, pulled to the middle ear. So the eardrum can be causing pressure on the incus, stapes, because it is very retracted. So that pressure can cause necrosis. It can cause the bone to erode. Like when you put this bony prominent on the table for 3 days, what will happen? It become black. So there's no blood supply there. Then it becomes eroded. So there'll be thickening of mucus secretion as well. Chronic otitis media can be complicated by cholestoma. When there's retraction, when there's negative pressure, the eardrum is retracted, especially at the attic. It's retracted at the attic. That skin which is retracted like a sac. So this normal skin cannot come out. So there'll be skin accumulated there at what we call keratin, accumulated at the pars flaccida. Why pars flaccida get retracted easier than pars tensa? Because pars tensa is 3 layers, while pars flaccida is just 2 layers and it's flaccid, not as tense as the pars tensa. So when it's retracted, so the skin, the epithelium cannot migrate out. So it accumulates there. When there's a lot of skin, sodden skin, a lot, layers and layers of skin, and it can get infected. It can produce bacteria. It can produce certain enzyme which can erode the bone. And also the pressure, the pressing accumulated skin can also press the bone, become erosion. Okay, next. Okay, this is the symptoms of chronic otitis media includes, there will be, this one is with perforation, chronic otitis media with perforation, will be ear pain, there won't be any ear pain, silap situ, correct that. If there's no complication, there won't be any ear pain. There'll be only discharge, perforation, but no pain. If there's ear pain, you have to be careful. There may be mastoiditis. There may be complications. There may be meningitis, for example. There'll be fullness to the ears, purulent discharge, hearing loss. If the eardrum is intact, there will be dullness, redness, or air bubbles behind the timpanic membrane. When you look like this, it can be either two. It can be a retracted eardrum or it can be a perforation. It can also be a retracted eardrum. It looks like a perforation, but the eardrum is lining the middle ear. Okay. How to differentiate that? There's several ways. You ask them to do Valsalva, whether that thing moves, or you can use a seagull speculum. Whether if it moves, that means seagull is pneumatic otoscope. If there's eardrum negative, positive pressure, it moves back. Negative pressure, it will suck it out. Then it is intact. It doesn't move, it is perforated. Or the tympanometry type B is type B with a large ear canal volume is perforation. Okay, next. So these are the chronic otitis media. We can do clinical examination, audiometry, tympanometry. We can, if we suspect or want to do surgery, we do a CT. MRI, we seldom need MRI for otitis media. A CT scan so that we can see how the condition of the bone, of the mastoid bone. Okay. The deficient diagnosis includes acute otitis media and cholestoma. We must determine whether there's cholestoma or not with that chronic otitis media. As I mentioned before, the complication includes distraction of the mastoid cells. There's a cavity in the mastoid cells. There can be abscess, mastoid abscess. It can be facial paralysis. There can be sensory hearing loss, vertigo. There can be extradural abscess, meningitis or subdural abscess or brain abscess. Okay. Or there can be there's a sinus, cavernous sinus behind. Posteriorly, there can be cavernous sinus thrombosis. Next. So the treatment includes, we give, if there's infection, we give antibiotics. For example, augmentin, twice or thrice a day. We can give steroids, ear drops. We can place tubes, grommet, if there's no profession yet. We can do mingotomy. If there's a profession, then and the ear has been dry for more than 6 months, we can attempt to close the ear. Because in a perfected ear, the infection can also come in from externally, from when they take a bath or they go into the swim in the river or the sea, can get infected. And sometimes we do a mastoidectomy. Mastoidectomy is an operation whereby you clean the bone behind the ear. The air cells may get infected due to otitis media, chronic otitis media, so you got to clean the ears, you drill the ears and then close back. Next. What is cholestoma? Cholestoma is something very important. Cholestoma is it's a skin epithelial cyst, a skin cyst consisting of disconnecting layers of scaly or keratinized skin. It's skin in a sac. The skin is layered skin, and it is in wrong place. Kalau skin in the skin, tak apalah. Skin, somewhere, there's the usual place. But in the middle here, there shouldn't be any skin. But if there is skin due to the retraction and the skin migrates internally, then you can have a condition called cholestoma, an epithelial cyst in the middle ear or in the mastoid. As I mentioned, there will be erosion of the ossicles. There are two types. There's also, to complicate more, there are two types of cholestoma. One is congenital and one is acquired. Congenital means during development of the ear, the cyst, the skin remain as a cyst in the middle ear, but the eardrum is intact. So that skin in the abnormal place too will grow bigger, and it will only cause problem when they are big, when they are maybe in the teen age or in the old age. They will have facial nerve palsy. But before that, you don't know because the eardrum is intact. Next. This is an example of cholestoma at the roof, at the attic. It's a cheesy white squamous debris, what we call keratin. And if you suck and smell the sucker, it's very smelly. It's a mousy smell. Why is it very smelly? Because cholestoma erodes the bone, eat up the bone. Yeah. So an eroded bone, a necrotic bone in the ear for many months, it's like macam bau tikus mampus. Yeah, like very smelly food remnant, meat or bone which is eroded, which is already denatured. Yeah. Okay, next. There can be cognitive deafness, as mentioned. So usually cholestoma, it needs operation, surgery. It's either we go through the ear canal, remove at the attic, we call ear, we do mastoidectomy. Mastoidectomy may be just a simple mastoidectomy, or we can bring down the we drill more the bone of the posterior canal wall. We call it modified radical mastectomy with the canal wall down. Canal wall up means it's like a cortical mastectomy. The posterior canal wall is still intact. Next, I don't want to complicate things. Next. So another middle ear problem is barotrauma. When you go down the airplane or you go down the Bukit Tinggi, Bentong or Karak. So suddenly when you go down, there's a change in pressure, external pressure. So that will also cause change in the air filling cavities. That is the middle ear. If the ascension tube is open, it's okay. The air exchange between the external environment and the inside the middle ear occurs. But if there's ascension tube is dysfunction, is blocked, then you have problem. You have what you call barotrauma. Hello.
Yes, Prof.
Dah tak ada. Saya rasa saya punya kamera. Saya punya, okay, hold on. I will come in with my handphone. Saya rasa my computer is quieting down or shutting down. Now I'll have to go. Hello, can you hear me now?
Yes, we can hear you, Prof.
Sorry, I have to use my handphone. Okay, barotrauma means, as I mentioned, change in pressure. It's either you go diving down or you on the plane, especially when you go down the plane from height. Yeah. Next. So if there is a negative pressure in the middle ear due to ascension tube collapse. If you go diving, scuba diving with a running nose, ascension tube is bad, then you'll have a lot of pain. You'll have because of the pressure, negative pressure, then there'll be effusion, and then sometimes there'll be even bleeding into your middle ear. Yeah. Okay, next. There'll be hearing loss, there'll be otalgia. Sometimes there'll be a small perforation. If you land from the airplane with a lot of nose blocks, then you'll feel this. Or you realize that children, when the plane start landing, the babies will start to cry. Cry, wow, wow, wow. So what do you do? What do you tell the mother to do? So you have to open up the oxygen tube. You ask the mother to suckle the baby or give some sweets. Yeah. Sebab in some aeroplane they supply sweets before you landing. You land. Okay. So that oxygen tube, because the oxygen tube opens while swallowing, movement of the jaw, yeah, and Wasawa procedure. Next. So that profession may heal up after a few weeks, or it may persistently cause discharge. So you can yawn, chewing gum, yeah, you can use decongestants. Kalau you have blocked nose, you still want to go up the plane, then you have to use nasal decongestants at least before you land. I mean, half an hour before you land. Or you can use do a meningotomy, put a grommet in, then the air can come in and out. If people with profession, you don't have barotrauma because it's perforated. Air can go in and out. There won't be any negative pressure. So patient education, including Wasawa maneuver. When you go for diving, they will train you how to equalize the nose, the nose and the oxygen tube. Every meter that every meter deep you go diving, you have to swallow, move your jaw, or do Wasawa so that it equalize the pressure. Okay. Okay, next. Okay, this is about mastoid. This part of the middle ear. SF, where there's SF connecting to the middle ear. Next. Mastoiditis, inflammation of this part where you have swelling behind the ear, redness, maybe any strep, pneumonia, or Haemophilus influenza infection. Next. This is an example, big swelling pus. Because once you get mastoiditis, it's inflamed, you have pus collecting there. That pus tends to escape through your bone. Your bone may be inflamed, there'll be a crack at the bone. The fluid can escape. Can escape to the skin subcutaneously, and you get an abscess like that. Mastoid abscess can be behind, can be in front. Benzoid abscess, it can be in the neck. Next. See, this kind will show some bony distraction. Next. And the complication is the same like otitis media. There'll be that distraction of mastoid bone. There'll be spread to the brain abscess, there'll be extradural abscess, in subdural brain abscess, meningitis, and so on. Next. So treatment also like media, antibiotics, or if there's a swelling there, it doesn't settle with antibiotic, we have to do surgical. IND first, drain the pus. Okay, next. Okay, I think that's it. These are just some example of a problem. If you see a ear like this, what probably is it? So it's probably, you see that there's swelling all over, not a furuncle, but all over. There's a, what we call generalized edema. So it's not localized folliculitis. So this is what they call, some call it the swimmer's ear. Otitis externa, diffuse otitis externa. Okay. What is the complication associated with this? As pain, it can become narrowing, hearing loss. Next. Treatment, you put as I mentioned, you have to clean it, a doctor will clean it, antibiotics, drops, steroid drops or ointment. We can also put thermoglycerin. We got to see it in the clinic. quite frequently. If it's very painful, swollen like this, maybe every 3 days until it gets better. Okay, next. What about this? Actually, this picture is we skip just now. It's there's granulation at the floor of the external ear canal. This is also otitis externa, but it's malignant otitis externa. If there's a lot of pain, patient said he wants to knock the head against the wall because it's so painful, then it's malignant otitis externa. Especially in patient with diabetes or on chemotherapy. Yeah. So we treat with antibiotics, long-term antibiotics, and maybe steroids as well, steroid drops. Next. What is this? The whole eardrum is blocked. Earwax. Next. Some people have been going around with earwax for years, so they thought the earth is the world is very quiet. Once they remove the earwax, the impacted earwax, said, wow, it's so noisy. I haven't heard this for long. Ini bullous meningitis. Okay, next. So what is this? And actually red bleeding in the eardrum. This can cause by barotrauma. And this patient went for scuba diving and had ascend there or descend there, not controlled well, very fast. So they can have barotrauma. Next. This is a 2-year-old present with bad cold, bad URTI, then a lot of pain, especially at night, crying, fever. What do you think this is? Siapa nak jawab? What is this? Ibrahim, what is this? Swelling, bulging, eardrum, pain.
Otitis media.
Huh?
Otitis media.
Acute otitis media. It's acute. It's very painful. Acute means there's pain, there's swelling. Kalau chronic suppurative, ni dia panggil ASOM, acute suppurative, there'll be pus behind that. OSCE, this picture may come out. You have to answer appropriately. Next. And this one, a child with a history of allergies, complaint of hearing loss to her right ear. This is not very red actually. Just that there's hearing loss. Sometimes you see bubbles inside. So what is this? This is middle ear with effusion or secretory otitis media due to negative pressure. Suction tube problem. Okay, next. Ni acute. Acute apa? You have seen this, you won't forget this. Acute. This is a complication of mastoiditis or acute otitis media. Acute separated media, which is mastoid abscess. Okay, next. You need to drain that or do surgery. Okay, next. Ini vertigo. No, we are not going in that. Next. Okay, at the end, yeah, we'll have some. Just at the end, will I include some other slides? Yeah, for those who are interested in acute separated media, it can be divided into several stages actually. We'll go fast. Okay, go ahead. Next. Yeah, this is the most common causes, shin tube dysfunction. Next. The different stages will be more common in children. Why? I've told you, we have discussed just now. Next. This is the predisposing causes. tumors on the esophagus, especially you have swelling, adenoids, tonsils and adenoids infection. Okay, next. Okay, next. Can I have these slides and we'll go through. Next. It can cause by viral or bacteria or mix. But next, usually there are several stages. First, the stage of shin tube dysfunction. Next. Next. When there's a shin tube blockage, the clinical pathological stage of ASM is tubal occlusion. You usually start with the tubal occlusion first. The tube, shin tube is blocked. Then you have pre-suppression before inflammation only, redness, pain before pus set in. Then you have suppression. Pus goes in, and the eardrum become bulging with pus. And then dissolution. Dissolution is when there's a perforation. Boom, pops the eardrum perforates, and the pain decrease, the fever decrease, because pus under pressure is no more there. Okay, because of the perforation. And then stage of complications. Okay, I think that's all. Okay, thank you. Sorry for taking extra time. Any questions? One or two questions?
I think no question, Prof. And if later, if have any question, we can ask you at the clinic, Prof.
Okay. Ibrahim, one question for Ibrahim. Ibrahim, extra sikit. Okay. Ibrahim, one question and we'll close. Yes. Usually mastocytitis, okay. Mastocytitis in acute suppurative otitis media, the TM is intact because the pressure, it goes to the mastoid and gets swelling and also abscess. But if it is because of the chronic otitis media, there's already a perforation and they get mastocytitis, then the external ear, there will be discharge. And there'll be what I'm saying that in acute otitis media, the external ear maybe there's no discharge, it's clean. There's no pain in the external ear, but the pain is in the mastoid region. When you palpate the simba concha or posteriorly or the mastoid at the mastoid tip. That's to say, mastocytitis, once again, mastocytitis can be complication of acute suppurative otitis media. Acute means intact TM before it perforate, or chronic otitis media. Chronic suppurative otitis media when there is already perforation and this infection spread to the mastoid area. Okay, thank you very much. Everybody have a nice berbuka. Sorry to disturb your weekend, your Saturday. The most important thing that I hope you all understand, so that when you go into the clinic, you have a good idea of what we are doing. Okay? Is that okay, Ain? Okay? Can we say, kita akhiri dengan tasbih kafarah dan wal asri subhanakallahumma bihamdika asyhadu an la ilaha illa anta astaghfiruka. Bismillahirrahmanirrahim. Wal asri innal insana lafi khusr illa alladhina amanu wa amilus solihat wa tawassaw bil haqq wa tawassaw bis sabr. Okay, selamat buka. May that be a purposeful time. Wal asri, demi masa. Okay, assalamualaikum.
Waalaikumsalam. Thank you, Prof.
Thank you, Prof.